All right, so before I begin, I'm really privileged to present this study on urine metabolomics profile in early CKD on behalf of a really wonderful collaborative team from RTI, Susan McRitchie, Vimal Patmasiri, Jason Burgess, and Susan Sumner, and of course, folks from Wake Forest, Tom DeBose, Jin Zhao, Shu, Lijun Ma, and Barry Friedman. So CKD stands, of course, for chronic kidney disease, and metabolomics is believed to hold a great promise in solving a problem of low sensitivity and retrospective nature of current clinical markers of CKD. In other words, we can't reliably diagnose early CKD when we can potentially intervene. And moreover, we can't predict who will progress, and that's the most important part, who will progress to end-stage renal disease and develop, so will need dialysis and transplants. Now, kidney disease is amenable to metabolomics analysis by nature of its association with metabolic diseases such as diabetes type 2. And in this analysis, we analyzed urine metabolic profiles from diabetic patients. And of course, by the very nature of its function to perpetually filter all the extracellular fluid, kidney function and kidney disease has a broad effect on circulating metabolites. Moreover, some of these metabolites may actually participate in the pathogenesis of CKD. Now, urine metabolomics profile gives us a proximal report on body's metabolic state, but also on all these other environmental factors like diet, gut microbiota, and so on. So a metabolite in the urine, its origin is not easy to trace. On the other hand, we can perhaps use this integrated response from the kidney and the environment with a careful analysis to get clues both about the kidney disease and environmental effects. So the goal of this pilot was to test feasibility of correlating urine metabolomics profile with early kidney dysfunction and with dietary acid load. So why dietary acid load? Because acid-producing diets facilitate progression of kidney disease. And I have highlighted here a study that has been done right here in San Francisco by Niels Power's group and has made headlines in kidney news recently. It was the last one in a series of cross-sectional longitudinal epi studies and small clinical trials. And this particular study was important because it has analyzed a representative nationally NHAIS study, so a nationally representative sample of CKD people, patients. And they have shown that patients with CKD who consumed high-acid diets were 3 times more likely to experience ESRD, end-stage renal disease, than were patients who consumed low-acid diets. So 3-fold increase. So when it comes to kidney disease, end-stage renal disease is really the hard outcome. And just very briefly, so what acid load that I'm talking about? Proteins in the diet, more precisely, amino acids, sulfur-containing amino acids, are metabolized to acid, to sulfuric acid, and kidney has to excrete that. And that's balanced by potassium organic salts, such as potassium citrate from fruits and vegetables, and one gets net dietary acid load. Now, kidney has to excrete this load all the time, and it turned out that this perpetual acid excretion of high acid load, which we find in our notoriously bad Western type diet, actually causes kidney injury. And so we also have animal models in which we study this incompletely understood mechanism. But important thing here is when we think about kidney patients, they are often acidotic, but that comes late in kidney disease. So these people, we are talking about metabolically produced acid, not an overt metabolic acidosis or change in acid-base, overall acid-base status. So we ask questions with this pilot. Is it feasible to associate a specific set of urine metabolites with early kidney disease? And can metabolomics actually indicate high net acid excretion or give us clues about particular diet patterns in people who develop CKD or those that progress. And so to answer this question, we have analyzed samples from our African American Diabetes Heart Study, which is a branch of a longitudinal epidemiologic and genetic study. So African American Diabetes Study is an expanded sample of the original Diabetes Heart Study, which studies racial differences in cardiovascular and kidney disease risks between European Americans and African Americans. And by the nature of the inclusion criteria in these studies, these people have been selected not to have kidney disease. So that was perfect for our purpose, because many cohorts that have kidney patients have actually rather advanced disease. And in the sample selections, these were the controls. So the controls had estimated glomerular filtration rate over 60 and ACR albumin creatinine ratio below 30, indicating normal kidney function. Smokers were excluded and very elderly. And so that was the sample for the controls. The cases included stage 3 or higher, so estimated glomerular filtration rate below 60, and stage 2, so estimated glomerular filtration rate above 60, but high albumin creatinine ratio in the urine. So you can see the problem right there. Our equation for calculated estimated glomerular filtration rate it just has a cutoff, and it's not very precise for the early disease. So this is so from these two groups, 50 samples were randomly selected and matched for BMI and gender. Oops. And so this is how the demographics of the groups looked. So it was matched for gender, age, and BMI, and of course it was different for creatinine, estimated glomerular filtration rate, and albumin creatinine ratio. But to emphasize here, if you look at the glomerular filtration rate in the controls and also in the cases, it's a fair glomerular filtration rate. So one of the things when people analyze urine metabolomics profile is, oh, well, that's maybe just a difference in glomerular filtration rate. So this is a fair glomerular filtration rate, so not a rate-limiting factor that would have major effect on the concentrations of the metabolites. In the middle, you can see, unfortunately, I can't use the pointer here, but in the middle of this table, you can see that we still were left with some variability in the risk factors for development of CKD, and I will come back to that in a minute. But we, just to talk very briefly about the methods, so we used, since this was an exploratory study, we used broad-spectrum HNMR metabolomics, and the raw data were binned, mean center Pareto scale, subjected to PCA and OPLS analysis, and bins important for distinguishing phenotypic groups were identified using variable importance to projections more than 1 or equal to 1, and then, of course, library matched. So here's the initial PCA. You can see the overlap and variability in PCA that was introduced by these differences. And so we adopted two approaches to deal with this variability. So one was to remove the samples with extreme values of blood pressure and glucose, and to remove the bins containing glucose, because the uncontrolled high serum glucose obviously caused glucosuria, and that was sending very strong signal overshadowing the signal from other metabolites. So once we've done that, we have lost some of this variability coming from differences in blood pressure and diabetes control, and have improved the separation of the group. So there's a PCA and OPLS-DA analysis and the list of metabolites that are featured. It's too bad I can't point. it's a very short time, so I can't unfortunately dwell on many of these metabolites, but amino acids and Krebs cycle, of course, feature prominently. But I would like to just point out that in context of the kidney, citrate and glutamine are very interesting because they are although we can't put a lot of weight on untargeted analysis, they seem to be decreased. And these are the very two metabolites that are used in the proximal tubule in a situation when we have to excrete high acid load. They are utilized to produce bicarbonate, the main body buffer. So we would expect them to be lower. We were also able to find distinction between metabolite, a distinct set of metabolites referring to CKD progression and fast progression. We only had 50 samples and 40 samples in this subgroup analysis, which have been followed longitudinally, so 3 to 5 years. And in those people, we can see that metabolomics profile nicely separated. Just to very briefly mention, at the end of the tables, you can see hippurate and trigonelline. Both metabolites actually have been linked to low consumption of plant food. And I have in the beginning mentioned that we balance our protein intake and acid production by intake of fruits and vegetables and base-producing food. So that was interesting. Of course, if we are talking about diabetic nephropathy specifically, then our real control group is are patients who have had diabetes for a long time, let's say more than 14 years, but did not develop CKD, and those who did. And so that separates very well. I think I will skip our other approach, which was to stratify the glucose level, so include the glucose containing bins, but stratify the analysis according to modest or bad diabetes control. So in conclusion, going back to the original questions, this pilot defined 3 sets of urinary metabolites that associated distinctly with early CKD, diabetes, nephropathy, or CKD progression. And amino acids and their derivatives and intermediates of citric acid cycle were consistently showing up in each of these analyses. Also, what gave us confidence about the approach, there are several metabolites which have been, like, for example, choline, which have been previously indicated as predictive of incident CKD, of new onset CKD. And so metabolites implying consumption of acid-producing diets were evident in patients with CKD and in those who progressed. Finally, why are we so keen on this acid effect in the diet on the kidney function? Because our long-term goal is to design interventions to slow the progression of kidney disease, of course, and changing dietary acid is relatively amenable and easy to scale, either by changing the diets, which is typically difficult, or by supplementing bicarbonate, and oral bicarbonate has been used safely in kidney patients for many years. And so we have designed this pilot as a part of a preliminary data for a study that we apply to, and because we want to take this into, we want to take this further to the elderly to verify some of the metabolites we have identified and to see whether we can link it with intervention and then actually measure acid load, change it, and see the metabolites that may change before and after. And with that, I will take any questions because I'm afraid that my time is up.
Any questions?
Thank you very much. Very important work.
Thanks.
Coming to the key issue of how you standardize urinary metabolomics.
Right.
So, what methods did you use as a reference? I mean, this was 24-hour urine, right? Or was it
No,
spot?
this was spot urine. We
Oh,
didn't
okay.
have 24-hour urines, and that's the purpose of this second study, the grant. We have just scored really well, so we hope to be able to do that. That's precisely what we have proposed, to do the 24-hour urines and have the intervention before and after. So at least the other confounding factors will be taken
But
out.
did you check on other confounding factors in your spot urine, like osmolarity, for example?
Yes, yes. I had to go quickly through the methodology, but we have scaled all the metabolites to the whole integral of, so individual metabolites to the integral of all metabolites that were present and that represented then the concentration, because obviously that's the major problem with analyzing urine metabolomics, and most of the studies that pertain to the kidney were actually done in the serum, not in the urine, because it's so difficult to standardize the analysis.
That was actually my second question. Did you measure serum or plasma metabolites?
I'm sorry?
Did you measure the plasma metabolites?
No, this was just the urine.
Just urine?
Yes.
Okay.
So it was just a pilot to see whether we have seen some clues, and I'm very happy that most of the other metabolomic studies which were done with the kidney samples and in the plasma, we have very similar metabolites cropping up, and it's just the direction of the change is different. But to be certain in the direction of the change, we of course have to repeat that with the targeted metabolomics.
Just as a comment, but people have left. There were some food metabolomics experts in the audience. And we also did some studies, and it looks like the osmolarity in urine is the best reference if you
Right.
want to standardize that.
Right.
Open for discussion. Okay.
Okay, well, we can continue afterwards.
Hi, very interesting study. As you mentioned, it's hard to separate the factors in terms of dietary acid with glucose metabolism. So is there
I'm sorry, factors? I didn't-
dietary acid versus glucose metabolism? You tried to omit the glucose bins and
Right.
showed that the main effect was dietary acid. But is there a correlation between dietary acid and measures of glucose control like hemoglobin A1C? And then secondly, in those patients that had long-term diabetes that did not develop renal failure, did they have better glucose control, or was it just an effect of the dietary acid?
Right. I'm sorry that for the shortness of the talk, I couldn't show those metabolic, the demographic tables for each of these groups. So yes, the answer is yes, they had better, somewhat better metabolic control, diabetes control. And the first question, which was what is the relationship of dietary acid load and diabetic control? The only study we haven't tested, because our sample was too small to have the significant difference in acid load. We can test it in the following study. But the only study I'm aware of was the one from the Nurses' Health study, which linked serum bicarbonate with new onset diabetes. So there might well be a link there as well. So it's hard to separate, I agree.
It would be interesting to look at patients that are getting high dietary acid diets with intense glucose control to try to sort that out.
Well, absolutely, yes.